September 2021 TOACS, there were 12 stations and 2 stations were resting. The other 12 were all interactive stations. First station scenario was given in which there was an IUD at third trimester, polyhydramnios था और patient उसमें बैठी थी और patient was very angry and she was asking about reason why this happened and complete management and mode of delivery. So you have to break the bad news and calm down the patient, tell her the reason. As in scenario, there was increased sugar and polyhydramnios, so likely it was due to the hyperglycemia, and you have to tell her to accompany someone, breaking bad news components and complete management with mode of delivery. She was para 2 with previous NVD, so obviously it would be normal delivery this time, and you will give her chances of coagulopathy, and you will tell her that up till 4 weeks we can leave you till spontaneous. Give her options of induction as well as spontaneous support and inhibition of lactation, that is tablet Dostinax, 2 tablets stat. Second scenario was about the instrumental delivery, 34-weeker baby in occipital transverse position, and the examiner asked you to pick up one instrument. So I picked up mid cavity forceps. She asked me what type of forceps this is and then asked me to apply it, and then the prerequisites and the complications and the diameter. Then comes the breech delivery. So breech delivery, she asked about the techniques, the contraindications of breech, and the maneuvers, that is the Lofset maneuver, the Pinard maneuver, Burns Marshall's Millibeat maneuver, and if head is not delivered by any of them, then what will you do? Then of course Piper's forceps and the complications associated with breech delivery. Then the fourth one was about the priority board. At one station you just have to sit and read the scenario and prioritize, in which 5 cases were given, and team was that you have 2 house officers, 2 R4 and 1 SR. So you have to distribute it, and you will have to decide that who is going to manage and who will do which case and on what priority level. Then at other station, examiner was sitting and asking you the answers of this priority board. On first station you were just given the scenario and a piece of paper, so you can decide and think about all of this. The scenarios were about uterine rupture. Obviously there was uterine rupture, you will do this case first, and that case will be given to senior registrar. Then the other was fully dilated bradycardia, and you have to apply instrument, so you will give this to R4. The other one was about the preterm rupture of membrane, so you will do that by a R4. And the 4th and 5th were that threatened preterm. So in threatened preterm you will just do conservative management. Management would be done by HO, supervised by senior registrar. She will take orders from the registrar. And the 5th one, that breech not in labor, so you just have to counsel her, and she was already 39 weeks in the scenario, so you just have to keep her on the list and do all the prerequisites and the pre-op preparation of the patient. So again that will be done by a house officer, but that will be supervised by a senior registrar. She will take orders from SR. The 5th one was the antenatal card. An antenatal card was pasted on one station, and it was given that you have to comment on the mistakes. So after seeing the antenatal card, there were so many mistakes. The husband name was not written, husband contact number was not written, patient full name was not written, residence was not written on that, EDD was incorrect, and there were no extra template to fill, and that patient also had a abnormal baby IUD, so nothing is written in remarks, as that has to be elaborated. So there were many mistakes one can easily pick. And on the other station, you have to tell the examiner that what are the mistakes in the antenatal card. First they give you station, so you can think and write on a piece of paper about the mistakes in the antenatal card. And on the second, you have to interact with the examiner about the antenatal card. The sixth picture was given about the imperforate hymen. It was a very clear picture and one can easily identify it. Question 1 was about identify, then she was asking about the clinical features other than pain and primary amenorrhea, and the management of it and the future plans. So management is obviously incision and drainage, and you have to reassure her and nothing else. And the seventh report was about there were 5 reports of complete blood count, and you have to diagnose each one of them and tell the examiner the management of each case. So first was about the iron deficiency anemia, in which the MCV, MCH and MCHC all were decreased. The second one was normal. The third one was macrocytic anemia. So she was asking about the management. Of course, you will do the serum B12 and serum folate level, and whichever is deficient, you will give that to your patient. And the third one was I think also iron deficiency anemia, and the fifth one was thalassemia minor, in which MCHC was normal. So she was asking the management, so obviously you will give her the blood transfusion. Then the 8th station, one scenario was given in which patient was at 9 weeks and she had 2 miscarriages and 1 IUD at 26 weeks. So you have to manage that and you have to diagnose it. So the diagnosis was antiphospholipid syndrome. And how you will monitor, you will do the feto-maternal monitoring by calling patient early antenatal visits, frequent antenatal visits, and dating scans, growth scans. And she was asking about the fetal and the maternal risk associated with it. How will you deliver her? So the mode of delivery will be normal vaginal delivery, as she was not a previous cesarean case. And management, you will keep her on folic acid, high dose, low molecular weight heparin and loperin. Then the other station was 2 CTGs were given and 1 scenario was given, and the fetus was in bradycardia. And the first CTG was that it has decreased variability. The fetal heart rate was fine, but there were no acceleration and no deceleration. Then after 1 to 2 hours, again another CTG was given. That was written in the scenario कि ये 1 या 2 घंटे बाद की CTG है, 1 घंटे बाद की CTG है और पेशेंट को हाइड्रेट करके की गई है. तो that was showing the late deceleration. So examiner was asking how will you manage it, as patient was just 4 cm and there was meconium stain liquor also. So the answer was you will deliver her by cesarean. Then the other station was about the neonatal resuscitation dummy. Neonatal resuscitation dummy with all the instruments and all the things and all the medications were kept there, and she was asking about how you will do the CPR. And she said if there is no heart rate, then what will you do? If there is heart rate that is 100 but there is no cry, then what you will do? If heart rate is less than 60, then what you will do? How you will do CPR? Demonstrate how you are going to pass laryngoscope. Yes, she asked that how you are going to pass laryngoscope. So I said that we in our setup don't do it and our anesthetists do it. And she was also asking about the intubation. Then the other scenario was about the HMB, heavy menstrual bleeding. She was asking about 3DDs, so one can easily tell about the 3DDs, as it was a 45-year-old woman, married para 2 or para 3, and she came with HMB for 6 months, I think, and the uterus was enlarged. So you can keep in your DD fibroid, endometrial hyperplasia, polyp. Investigations, you can tell all the investigations of the heavy menstrual bleeding, starting from the complete blood count, the ultrasound pelvis, the hysteroscopic sampling, and if that goes on, then the pre-op counseling, what you are going to counsel her and what you will do in her management. The management will depend on the cause of this heavy menstrual bleeding, including the medical management and the surgical management. Then comes the 12th station. The multi-load was lying there with the uterus dummy, and you have to demonstrate on dummy how you are going to insert the multi-load. The question she asked was what were the prerequisites, how you are going to counsel your patient, and when you are going to call her on follow up. So you will call her on follow up at 4 to 6 weeks in her first menstrual cycle. Thank you.